Morning everyone. Had a bit of a panic then with buttons and everything. Right, it looks as if everything is good. Looks like we've got some people online as well. So we're ready to go. Well, we're on to the next bit of the body now. So we've done the foot and ankle. Then we moved on to the knee. And yeah, last week we finished off the nerves and the blood supply for the knee and all around the kneecap. And then now we're on to the hip. So we're going to go through that same process again. So we'll start off with all the bones and bony landmarks. Just grab my comments. My comments are in the wrong place. There we go. That's better. Yeah, and I'm going to bring a little bit of clinical practice stuff in here as well, because bones and bony landmarks, they're often used for assessments. So we need to be a little bit critical of those. So here we go. Good morning, Caroline. Good morning. All good, thank you. Good morning. Well, thank you very much, David. As always. Yeah, cool. So let's get you guys going. Just pop that one on there. There we are. Okay, so yeah, bones and bony landmarks first of all, and then we'll start adding the layers of tissue on as we go. We've done a couple of these already because we've looked at some of the muscles that attach to the knee or cross over the knee, also crossed over the hip. So there has been a little bit of a crossover. But what I've tried to do is focus the attachment points of those muscles that do cross both down at the knee on the last section. So we're going to focus it more on the hip for this one. So there will be a bit of a crossover, but I don't think that's a bad thing. I think sometimes we need to go over things again and again. Right, and talking to that, here is a. Just going to switch my mouse there because that was a clicky one. It does my head in after a while. Right, okay, so we've got anatomical terminology. So we've looked at some of this already and kind of started to sow the seeds of it over previous sessions. But this is really evident in these sessions coming up because they are everywhere. So we've got ramus, which means a branch. And you'll see this word used quite a bit, especially around the pelvis, because there are rami or ramuses around the different parts of the pelvis, and they relate to the different sections of the pelvis as well. So once you know what ramus means, and then you know the region of the pelvis, then again the names start to make sense. You start to understand them rather than just remember them. Tubercles and tuberosities, they are lumps and bumps on your bony anatomy. So a tubercle is a lump and a tuberosity is a bigger lump, and then one that's missing from there is an even bigger lump, which is a trochanter. Okay, so we've got tuberosities, tubercles, trochanters. All of those are lumpy bits of bone. And again, if you've not watched any of my sessions before, then you may find it interesting. I don't know. But the way that these lumps form are because of muscle attachments. So when the muscles attach into the bone, there's a covering around the bone called a periosteum, and then that periosteum is a kind of anchor point for muscles and ligaments. But obviously the muscles have got contractile tissue in, so when we move, you contract the muscle, and then it pulls on the periosteum of the bone, and then this starts to stimulate what we call osteoblast activity. So it's the bone building cells, and again, way to remember that is blasts or blasts, depending on where you're from. Blasts, they build, and then clasts clear. Yeah, so osteoclasts are clearing cells, so they clear bone. You get some degradation of bone, and then blast cells are building blocks for bone. So this osteoblast activity that goes on when the muscles pull makes these bigger lumps. So when we talk about tubercles and tuberosities, the size of the lump, it usually corresponds with the size of the muscles that are in that area. So tubercles, they usually around the shoulder. Okay, so we've got a couple of tubercles in the shoulder. Tuberosities, there's some in the tibia, and then we've got trochanters, which are around the hip. So if you think about it, we've got big glute muscles around that area. We've got lots of muscles attaching into a particular trochanter, and so they're going to generate a lot of force and create quite a big bony lump. Okay, so that's why they form. So that is one of the big reasons why we have differences in these bony lumps, these bony landmarks, because of how they're formed. Okay, so and we'll talk a little bit more about that as we go through. There are a few fossas around this region as well. So a fossa is a dip or a shallow in a bone, and usually the bone is kind of curved and then it's filled with something, and in this case around here, usually a muscle. Okay, so a muscle fills that fossa, and then we've got a foramen or a foramen, again, however you want to pronounce it, and that is an opening. And we've already had a look at that previously, because we were looking at the obturator foramen, which is where the obturator nerve comes through, which was our last session. So we've had a little bit of an introduction to these already, but now we're going to start to see a couple more examples. So this is your pelvis and what it's made up of. So just given each of the sections a bit of a different colour, and it's divided through the socket, through the hip socket. Now this socket is called an acetabulum. Okay, we'll explore that a little bit more in a second as well, and the reason why it's called that. But yeah, basically we've got these three regions. So we've got this red region here at the top. This is your ilium, or ilia, if it's the two of them, and that basically just means wings. Okay, so obviously this is a side-on view, but when we have a look from the front on, they do look like wings coming up over up into the abdomen region. So we've got the ilium. We've then got your ischium, and your ischium, if you've never looked at this part of the body before and you've never really understood it, or not really looked at the names of things, best way to find your ischium is sitting on your hands, and then if you wiggle about, then the bones that you can feel on your hands, those are your ischium bones. Okay, so you've got some muscles that attach into there, which we'll look at when we start to add on the muscle layers as well. And then around the front is your pubis. So we've got your pubic bone at the front there, which is obviously the pubic region at the front of the iliac crest, and around that area as well, all at the front of the pelvis. That's the word I was after. And then we got the femur, which attaches into this acetabulum, into the socket. Okay, so what we'll start to do is start to look at the pelvis in a bit more detail, because on this image here, you'll be able to see there are these kind of lines around these areas. So lighter areas and then darker areas, which indicate that there are ridges, and there are, yeah, and muscles will attach onto these points. So, and they're quite useful whether you do manual therapy, so if you're doing massage, or doing injection therapy, if you're doing like shockwave therapy, if you're scanning, that kind of thing, because then you'll know, you can get a good orientation of where things are and where they attach. Okay, so that will be hopefully quite useful for you as we go through. So from the front, here are your wings. Yeah, so you can see the wings here. These are your ilia, and then we've got the ischium at the bottom. So that's your bum bones. When you sit on your hands, that's what you can feel. And then the pubic bone right at the front. Okay, or the pubic region right at the front. Now, you'll see on the on this picture here, we've got these white areas which are connective tissue, and these are ligaments that are they form a movable framework for this pelvis. Okay, so we've got a ligament at the front, which means that the pubic region at the front can move. Okay, very, very slightly, but it can. And then we've got this region at the back as well, which is the join between your ilium and this bone here, which again we haven't really looked at before, but this is the sacrum. Okay, so this is the lower part of your spine. So we've got your joint between the sacrum and the ilium, so that's your sacroiliac joint, and this is a view from the front of it, so this is the anterior sacroiliac joint. Okay, so just to give you a bit of an orientation of where things are. So those are your main regions. And then we've got joints as well around the pelvis and the hip, and there are three. There's the coxal joint, which is the medical term for the hip joint. Okay, so the ball and socket joint of the hip is the coxal joint. We've got the sacroiliac joint, which we just mentioned, and then at the front where the pubic bones meet, and then there was that connective tissue between the two, is your pubic symphysis. Okay, sometimes it's said the other way around, sometimes it's said symphysis pubis, but it doesn't really matter which way you say it. So yeah, there's your sacroiliac joint, and that is often shortened to SIJ. Okay, so you might hear people use that term. And then the pubic symphysis at the front, symphysis pubis, and then the coxal joint, which is your hip joint on the side. So we'll start to add on the femur in a second, and when we get to the connective tissue, you'll see how those two start to link together. So yeah, your pelvis is made up of these three bones, which we've just looked at. So ilium, ischium, and pubis. And the main function of the pelvis is this transference of weight from the vertebra to the legs to the vertebra, vice versa. Attachment sites for muscles. So remember I was saying about those lines and the fossas and the tuberosities and all that kind of stuff. All of those little bony lumps, those are attachment sites for muscles, and obviously withstanding compressive forces as you walk and as you run. So your pelvis has to move. Yeah, so there is an element of movement there, but the movement is very small. It's somewhere, especially the sacroiliac joints at the back, been measured in some papers to be between about 2 degrees up to maybe about 9 degrees. So there is a little bit of kind of leeway with the amount of movement that you've got. But the thing that I always think about is if you imagine back to school when you had one of those protractors, those semicircular shaped measuring devices, and you think about the amount of degrees that 2 degrees is. Yeah, it's absolutely minuscule. So if somebody's sacroiliac joint does move 2 degrees, and that is it, yeah, so it does move, but only that much, then now once we start layering the tissue on, just want you to have a think about how can you possibly feel that movement through all of the tissue. Okay, because I think it's I think there is evidence that it does move, but being able to reliably feel that movement is questionable. Right, this is a big one. Lots of information on here. So what we're going to do is going to do some of these, pick out some of these, and then we'll have a look at some videos and we'll show you them on a dissected model. So we've got this is a side view, so we've got a right pelvis, lateral view, and what I want to go through is not just naming all of these, but also the different shapes that are possible, okay, and the different variations that we may have. Because one of the things that you may get taught is to use, let's say, this here. I've chosen something that isn't labelled. Brilliant. So this is the iliac crest, just here. But what is labelled is the front of it, and that's called the ASIS. Okay, and then the back of it, which is the PSIS just there. So if we have a look at the name of the ASIS, this is the anterior, so it means at the front. So this is the front of the pelvis. Superior, because it's high. Iliac spine, which is that. Okay, so the whole thing is the iliac spine. So this is the anterior part of it, the anterior high part. If we look underneath, there's an anterior low part as well. So this is the AIIS just there. Yeah, so that one's quite important. And then this one at the back is important as well. This is the PSIS, posterior, superior, iliac spine. So this is the knobbly bit basically at the back of the pelvis. So this is the posterior aspect just here. So that iliac crest, often what you'll see is you'll have someone stood in front of you, or either facing away or facing towards you, and you'll put your hands, if I just get the camera right, put your hands like that on top of the iliac crests, and then you'll go, yeah, that one's higher than that one, or that one's lower than that one, whatever. Okay, here's the problem. The distance from here down to here can be different, okay, quite significantly different as well, on the same person from side to side. So when you measure it and one's lower and one's higher, it could be that one, it is lower, but it's because it's lower. The actual bones are shorter on that side compared to the other side, which are higher. And as we go through, I've got some good papers for you guys to look at. So we'll, if you're interested in this kind of thing, but if you have a look for anomalies or changes in morphology, something like that, in your search terms for bony anatomy of the pelvis, it will come up with a number of studies. Okay, so you'll be able to find this out for yourself. But the height from there to there can differ. It differs from person to person. It differs from side to side. So the point of telling you that is it's not a very reliable measure. So if you are using it to measure things and you don't have x-ray vision, so you can't tell, how do you know whether there is a change for whatever reason, or it's just physically that the bones are shorter on one side? Okay. The other thing that is different is this. Okay, so again, this is something that is often used. So you'll have someone facing towards you, and you'll put your thumbs on their ASIS, and you'll see whether it's tilted. So one side is down and one side is up, or the other way around, however you interpret it. So the issue here is the size of this ASIS can differ in length. So you can have one that's that long, one that's that long. So when you feel the ends of the bone, you go, oh, this one's rotated forward, that one's rotated backwards. It may just be that the ASIS is shorter on one side and longer on the other, or the other way around. Okay, so again, it's not a very reliable measure for any kind of decision making. Yeah, because it can be different from side to side, it's different from person to person. And the same is true for the PSIS at the back as well. Okay. And when you think about how these bony lumps are formed, they are formed by stresses going through them. So things pulling on them. Yeah, our bodies developing over time give us our unique bony landmarks. And it's that makes it an unreliable measure, because everybody is different. Everybody's life has been different. Everybody's activities levels are different. So you can't reliably use bony landmarks as measurements because they are just different. Okay, and we'll look at that more and more as we go through. So that's just that bit there. Okay, a couple of things I want to point out to you, for especially when you're if you're palpating for symptoms around this this kind of area. So a patient may come in and they say, I've got a really bad back. Okay, so you go, okay, can you point to where the problem is, where you feel it? And it's all here. Okay, so it's on the top of the pelvis. because automatically people get worried that it's their spine, but they have no problem with their spine. It's not sensitive. It doesn't. You test it. It's not sore when you press it, but when you press here, that's their pain, and that's where they feel it. Okay. Good thing is that's not their back. That's where muscles attach onto their pelvis. So that's a really nice thing that you can say to someone, that it's unlikely to be your back, because we've just reproduced your symptoms and it's on the pelvis and it's in these muscles, rather than it being to do with your spine. Okay, so yeah, we can use that as a to help us find out whether it's something that we need to be worried about. Is it something to do with their spine, or is it more likely to be muscular and around the pelvis? Okay, so can you see these lines here? There's an anterior gluteal line just there. There's a posterior gluteal line just there. These are really common hotspots, yeah, where people are sensitive all around this area here. And if you do manual therapy, pushing into people's muscles around the hip and the pelvis, quite often these are the areas that are tender. And we'll talk about referred pain another time, but you can get referrals from this area that mimic radiculopathy problems, so problems to do with the nerve root. Yeah, so some kind of radiculopathy. So then we've got inferior gluteal line just here. Okay, so this one just above the socket, the acetabulum. So there's your acetabulum just there, and there's a couple of different surfaces on this acetabulum. We've got a lunate surface, and lunate means moon. So it's this moon-shaped crescent, really nice smooth surface of the acetabulum just here. So we get a nice glide and movement of that hip joint. There's your ischial tuberosity right at the bottom. So remember we were talking about tuberosities and tubercles. Tuberosity, so we've got a lumpy bit on the bum bones, and it's lumpy for a reason, because some muscles attach into there and they've made it lumpy. Okay, so that's that bit just there. Here's another one of those words that we saw at the beginning as well, ramus. So this is a branch of the ischium. Remember this region here was the ischial region. So this is a ramus of the ischium. There's your pubic tubercle. Yeah, so we've got a tubercle there and a tuberosity there. They both just mean lumpy bits. Okay, so we've got lumpy bit at the front, lumpy bit on the bottom. Cool. And I said I wasn't going to go through it, but I did. But there we go. I think it needed to. Let's have a look at this. Just going to flip that up there. There we go. Okay, so this is a model of a pelvis. So this is the right side. There's your pubis. There's your acetabulum just there. That we haven't really discussed yet, but that we looked at these on the last few videos. Obturator foramen, so that's the opening between the pubis and the ischium, and we've got muscles that attach into there, and you may have heard of some of them called obturator muscles, but the obturator nerve comes through there. We looked at that last week. So yeah, again, if you know the names, it helps you understand the rest of the anatomy. There's your ASIS, and that's the thing that can change in length. Okay, so you can have one longer than the other, one shorter than the other, and it's just natural variation. And this side can be longer than the other side, so it's different from side to side. Okay, there is a whole book on anatomical variations. It is huge. It's about 1,000 pages long. It's massive. Here's your iliac crest over the top. Okay, so that links your ASIS at the front to the PSIS at the back. So it's your posterior superior iliac spine, anterior superior iliac spine. Okay, so that's what they are called. And then as we spin around, there's the socket. There's your iliac crest all the way around. And we can start to see some of these lines that are there on the side of the pelvis as well. So there's your anterior superior, there's your posterior superior iliac spine. Now that one there, that's a cool one. So that's your ischial spine just there. When we start to add on the ligaments, that becomes important. And this is important when we start to look at nerves, okay? And you may guess which nerve goes through there because it's called the greater sciatic notch, okay? So this is a notch in the pelvis. It's not like this when in a living body there's other tissue that create like a tunnel for the sciatic nerve to go through. So we'll have a look at that when we get to that section. Cool. So there's your lesser sciatic notch. So we've got another little notch at the bottom. Ischial tuberosity. So that's your bum bones. Then the ramus just here. So the hamstrings attach into here. And that's the reason for the tuberosity. Yeah, because of the hamstring attachment. Perfect. Just check on messages. Sorry, I've missed quite a few. What would be the reason for the variance in movement? Would it be things like hypermobility, and what else? Movement of the sacroiliac joint. Yeah, it could be hypermobile. Could just be the shape of the joint is different from person to person. So the sacroiliac joint is what we call auricular shaped. Let me just type it because it sounds like it should be said spelt differently, but it's auricular like that. Okay, so the shape of the sacroiliac joint is auricular, which means like an ear. Okay, so it's curved like an ear, so it doesn't hinge, it glides. Yeah, so it's like a C shape. And and when you see the inside of the joint, it's like some bits are convex and some bits are concave, so that you've got sticky out bits and like a indentation, and they then fit together and to form that joint, and they can just be different from person to person. But it could also be a connective tissue disorder. Yeah, you're right. So if they've got some kind of hypermobility on the spectrum of hypermobility syndrome, then yeah, that could play a role as well. That can change from time to time. So obviously if pregnant, during menstruation cycle, it changes from time to time as well. Yeah, it can be varied. So you might assess someone one day and then they move in a certain way, assess them again another day and they move differently. Right? So again, the reliability of the testing is not very good. Oh, okay. This is definitely worth a mention. Did this and we're told my pelvis is so out and he's clicking back in. Oh, it's one of the reasons why I do this because it's a very common thing that we hear. Just the reliability of the palpation in that area is so poor but the very notion that you think that it's out, like like dislocated, it's just wait until we see the ligaments, and yeah, good luck with having a pelvis that is out. I think one of the things that the arguments that you hear quite a bit is well, it has to be out, yeah, because when I do my treatment to it to put it back in, the patient feels better. Okay, so it must be that. And then think, well, actually, what else could be making them feel better? Yeah, what else does that treatment do? What other things does that treatment affect that could make that person feel better? Okay, and once you start to think about other things that may be influencing the way that that person's feeling, then we may get the right answer. Okay, I'm not saying that I've got the right answer. I'm just saying it's unlikely to be that one. There we go. Right, so let's have a look at this. So this is the view from the inside. Okay, now this is a really nice one. There's the auricular shape of the sacroiliac joint. Okay, so you can see it does look like an ear. properly looks like an ear. So like I said, we don't get this kind of axis of rotation, because that's how, when I studied osteopathy, it was taught in that way, that the sacrum had all these axes of movements, but it's more of a kind of a scoop, if you like. Right? So because of the shape of the joint. So this can be different. The shape of this can be different from person to person, so that's why it moves differently. Yeah, I'm not surprised. Yeah, I think that's a real good point. Is saying things like your pelvis is out really gets people worried. Yeah, because if you think that your pelvis can dislocate, and that's the image that you have in your head from the activities that you've been doing, like running, jumping, going to the gym or whatever, and that's the reason for your symptoms, then that makes your body very vulnerable, yeah, in that person's mind. And that is a really bad message to send about one of the structures in the body that is one of the most solid, yeah. And there's so much force can be absorbed by this region because the design of it is so amazing. And to lay that kind of thought into someone's, when they're already in pain, is it's really damaging, or can be damaging. So yeah, sorry you were told that. Right pelvis inside. There's your iliac crest from the inside. Then we've got this shallow or dip, okay, on the inside of the pelvis. This is called the iliac fossa. Remember, a fossa was a dip. There's another ramus, so we've got a branch, yeah, of the pubis, and there are two. So we've got a superior branch and an inferior branch of that pubic bone. So these are basically an upper branch and a lower branch coming off of that pubic bone. These become important later on when we're looking at the pelvic floor muscles and around that region. Okay, so it'd be useful to keep those in your mind for later. There's your notches that we've just seen. So greater sciatic and lesser sciatic notches just there. And then an opening, again, the obturator foramen, which we saw from the front view a little bit earlier. Cool. So yeah, it obviously looks a little bit different from the inside. You don't usually, or you can't palpate this area, so you don't really have a kind of image in your head of what it looks like until you see it. And then this is from the front again, just some of those things that we've just seen. So inferior ramus of the pubis, your ischial tuberosities again, superior ramus of the pubis just here. So obviously this is the pubic symphysis. Pubic tubercles, these become important when we're looking especially at things like a herniation. We will do a session where we look at the inguinal ligament, and especially how the spermatic cord travels from the abdominal area into the testes, because it's obviously got to get outside of the body. So this region here becomes really important. So useful for if people have got groin pain, and that they're coming to you thinking that they've pulled a muscle, but it could be a herniation. So we'll look at that where it'll probably be a few weeks, maybe even in the new year. So we'll look at that. There's your iliac fossa, iliac crest over the top, ASIS, AIIS, all from a front view. Okay, so that's kind of rounds those ones up. Let me just show you this as well. Yep, so we've got a little video here on the acetabulum, so the socket, and the pubis and the obturator foramen, so around that area. So let's have a look at that one. Just pause that there. There we go. Move me out of the way. So the acetabulum, this bit here, you can see that lunate surface there. Remember I was talking about that crescent-shaped smooth surface? So that's that. You can see where it's a little bit bobbly in there, and then it's nice and smooth all around there. Yeah. This is the acetabulum, and you think, what the hell is that down there? This is from Roman times. this is a vinegar cup, okay, and it had a specific cup for vinegar, and it looks exactly like the same shape as the acetabulum, and that's why it's called that. Okay, so we've got the vinegar cup, which your femur will go into, the pubis at the front, and then the obturator foramen, which is this big hole here. Okay, so let's add some more things onto that. So there's the lunate surface, or the articular surface. Articulation just means a join. Yeah, so this is where the head of the femur will join into that socket. Obturator foramen just here, and then the body of the pubis, superior ramus, and then the ischio-pubic ramus, or the inferior ramus. Pubic tubercle, so again those bony lumps on there. Now that's a good spot actually. Let me just pause that there. Okay, can you see those little lumps on the pubic tubercle just there? So sometimes you can have a condition called osteitis pubis, and where basically you get this inflammation of the bone. So osteitis pubis is on the pubic tubercle. Yeah, so it's right on there where it's sore. And if you have a, again, if you're interested in this kind of thing, if you search up for ultrasound scans of osteitis pubis, you'll see just this roughening of the pubic tubercle, where again the bones have just been pulled. You've got this little bits of bone are called osteophytes. So you've got this osteoblast activity have created these little osteophytes because of the pull of the muscles over time. Okay, if the stress going through that tissue is a little bit higher than usual, then you can get inflammation, and inflammation is a chemical irritation, and you can have pain. Okay, so you'll get osteitis pubis around that region there. Cool, right, we're doing good. This is a view from the back this time, so posterior view, and these are these white areas again. These are ligaments, and remember I said that some of the bony landmarks from the other sections will become useful when we start to lay the ligaments down. There's your PSIS at the back. Okay, there's your another iliac fossa, but this is on the posterior aspect, so your gluteal muscles will attach into here, and then there's your iliac crest. Okay, we've got the ramus of the ischium, so the branch of the ischium this time, and then your ischial tuberosity, so your sit bones at the back there. That bone there is your sacrum, and then these are your lumbar spine. Okay, so that's where your spine is. So like I was saying before, when someone says, oh, I've got a really bad back, you go, can you point to where it's painful? And they point to here. Yeah. So yeah, well that's good, because that's not where your back is. Yeah, so because well, it is obviously the posterior aspect of their body, but they would probably be worried about their spine. Yeah, and the problem is that this area, as I was saying before, if there's symptoms here, it's irritated, you can get referred pain down the leg from this area here. So if someone thinks it's their back and they're getting pain down the leg, automatically they Google it and they think they've got some kind of horrendous disc herniation. Okay, so if we can do a thorough examination of this area here, see if we can reproduce their symptoms by pushing on some of these muscles, then that can then affect your clinical reasoning. Okay, so all the other tests are clear for the nerve root stuff, and then this is positive, it's more likely to be that. Okay, so let's have a look at the femur as well. Okay, I'm just gonna, in fact, before we do that, let's show you this one. So another one for the pelvis, and then we'll move on to the femur. Let me just finish this one off. Okay, so there's the joint. Hold on, let me just. So look at that joint there. Yeah, look how thin that is. Again, think about 2 degrees of movement, and I'm pretty sure it's up to 9. If it's more, then it won't be much more, be a couple of degrees. But yeah, think about that level of movement in that joint. And then this is obviously got no soft tissue on. there's no ligaments, there's no muscles, there's no fat, there's no skin. Yeah, and then being able to feel through all of those layers 2-degree movement in the sacroiliac joint. Good luck. Okay, there's your sacrum, iliac crest, ASIS just here. So those are all the bits that we've seen already. Sacroiliac joints, pubic symphysis at the front. So there's this bit of cartilaginous tissue at the front, which is like a bit of a buffer between the two pubic tubercles. There's your acetabulum. Okay, there's the split. So you got the ilium, ischium, pubis, which was that first image that I showed you today. There's the pubic body, pubic tubercle, lesser notch, greater notch, wings, so ilia, and then obturator foramen at the bottom. And then just something that I want to go over, there we go, that very first word that I skipped over. So we've got the hip pelvis rather than hip, innominate. Innominate bone means the bone with no name, okay? But the very fact of calling it innominate, you've given it a name. But there we go. So you might hear about it being called the innominates as well. Yeah, the innominate region, the innominate bone. That's basically what it's your pelvis. Yeah, so it's the ilia of your pelvis. It's usually what people are referring to. Cool. Okay, let's have a quick look. What time is it? Quick look at the femur. And I'll show you a quick video and then we'll do a recap of the last little bits next week. So here are some more lumps. Trochanters. Yeah, remember I said the trochanter was a big lump. We've got a greater one, really big, and a lesser one, not so big. Still pretty big, but not as big as that one. Okay. You've got the shaft of your femur. Yeah, we've been looking at the other end of this when we've been looking at the knee. Here we are around the hip. And then these bits, these white bits here, this is the ligaments. These are the ligaments of the hip. These are really, really tough. Okay, very, very strong ligaments. They have to be because of obviously all of our weight is going through this region. So when we run and walk, we've got all of the forces as our body hits the ground coming up through our body, distributed through various structures and specifically around the hip. Okay. And then there's your ASIS, AIIS, obturator foramen. There's your pubic bone at the front there. Okay, let's just have a quick look at this video and then I'll see you next week. Okay, here we go. So there's your femur. That's how it attaches. There's your greater trochanter. There's the head of the femur just there. The neck. Greater and lesser trochanter, and that's how it fits in. So look at the movement of that. Okay, so what just want to mention before we go this week is the shape of this head. So remember I was saying that different things got different shapes and they develop over time and depending on what you do. You may have heard of FAI, femur, acetabulum, impingement, FAI. And some of the reasons why this occur is because of something called a cam lesion or a pincer lesion. Now a cam lesion is where the head of the femur is not spherical, like perfectly spherical. It's an odd oval type shape. So when you move into certain directions, it doesn't spin in the socket very well and it will get caught on the edges of the socket of the acetabulum. So that is a cam lesion where the femoral head changes shape. You can also have a pincer lesion, which is where the socket changes shape. So the socket can grow outwards and it will, these little osteophytes will come out and they will create a deeper socket. So as you move the femur around, it can then contact those pincer points and you can get irritation there. Okay. Now, most people will have those changes. Most people will have cam or pincer asymptomatic. No problem at all. Okay, sometimes they get quite big and they can be an issue. Sometimes it just gets irritated. Yeah, so it's a bit of inflammation there, and then you have a scan, you see those changes, and it's like that's the reason for the changes. But those things don't happen overnight. They take years to develop, or you may have already had that kind of shape when you were born. Yeah, so sometimes they are inconsequential findings. So if you scanned most people who are asymptomatic, they will probably have those different shapes of either socket or femoral head. Okay? So again, more anomalies around this region. Cool. Done for today. Hopefully that was useful, and try to, like, for beginners, hopefully that was a good introduction, but also if you've looked at this kind of stuff before, just try and layer on some of those clinical points. If you're treating people, assessing people, then these are the things to look out for. Brilliant. I will see you next Monday, 10 o'clock. We'll finish off a little bit more on the femur, and then we'll start to move into the connective tissue. See you then.